I'm very proud to introduce Dr. Maxime Patou, who is a consultant respiratory physician at the La Pitié-Salpêtrière Hospital. My French is terrible, I apologise in advance, and the Sorbonne University. He is well published in the area of non-invasive ventilation and high flow therapy. He's an emerging celebrity at the ERS as well, and it gives me great pleasure to hand the floor over to him. So Maxime, over to you.
Thanks, Michelle, and thank you very much for the invitation and for the nice introduction. So yeah, I'm a bit jet lagged, so hopefully you won't mind if I have a few misspelling while I'm speaking. So it's my pleasure really to discuss with you the topic of the use of two different treatments that may be used in COPD patients in the home settings. So either nasal high flow cannula therapy or non-invasive ventilation. As Michel said, as most of the chest physicians have been working on NIV for quite a few times, and it's very exciting for us to have a new therapy, and we will discuss a little bit where it sits in the management of the patients. So first of all, I have a few disclosure with a French home care provider that are delivering NIV and oxygen in the home setting, from the pharmaceutical industry that are working in COPD patient, and also for manufacturer. And I've been fortunate enough to have a grant by BREAF to do some research while I was working in England a few years ago. So now let's move to the outlook of our talk, and we're going to divide it in three different parts. The first part will be to discuss a little bit and to introduce to you what are the main differences between non-invasive ventilation and high flow therapy. Then we will move a little bit to discuss a little bit what are the needs of patients with severe COPD, and we will see how this therapy may help us delivering a better care for the patients, and we will see if there is one that is better than the others, and then we will put that into context and try to see where it may fit in our daily practice. So let's start with the introduction. So as you are following BREAF educational seminar, I'm pretty sure that you are familiar with non-invasive ventilation, so I won't go into much details on that aspect. But just a few words to remind you that the ventilation that we are using is basically a turbine that is generating a flow in a closed system, and by doing so, it will deliver a pressure to the patient, an expiratory pressure and an inspiratory pressure. So if we put that on the screen and have a look at a few graphs, you can see that you have lots of settings that you need to set up when you are using non-invasive ventilation. You need to set up the expiratory pressure, the pressure that will stay inside the patient's lung when he's breathing out. You need to help the ventilator to identify when the patient starts to breathe in, so that the inspiratory trigger, then the pressure goes up, it's the inspiratory pressure, and that will generate the pressure support to help the lungs inflate and get rid of the CO2. And then the ventilator needs to identify when the patients want to breathe out so that he can get rid of the CO2. So NIV has been on the market for several years. It has changed lives. It has changed everything in the field of respiratory medicine for neuromuscular disease. And recently, there's been some evidence showing that it was useful also in COPD patients. But as you can see, there's lots of settings. It's a closed system, so the patient may feel a little bit claustrophobic. And usually they have a bad experience with NIV in the acute setting where they are very breathless. Now let's move to high flow therapy. So high flow therapy, it's still a turbine, so it's still something that is generating a flow of air, but the main difference is that it's an open system, which means that the patient will be free to speak, but which also means that the pressure that is delivered in the patient's airway will change if the patient opens his mouth, for example. Then the other thing that is very specific with high flow therapy is the fact that the air is warmed and humidified, and that's not the case for non-invasive ventilation, or it's not to the same amount of warming and humidification, because you can have an humidification in non-invasive ventilation. So if we do the same type of graph as for non-invasive ventilation, you rapidly see that it seems much more easy. You just set the flow. You don't have to set a trigger or something else. You set the flow. you need to set up the temperature, you need to adjust a little bit the flow of oxygen that you want to add in, and then it will be very easy. But as you will see, when the patient is breathing in, the pressure will drop. And that's the reason why in most of the trials that we will discuss, the high flow is not used in patients with OSA, because we know that the pressure that is generated by the high flow is not good enough to overcome upper airway obstruction. Because it's a closed system, it's an open system, the high flow therapy will do something that is not done as well by non-invasive ventilation. Non-invasive ventilation helps you to get rid of the CO2 by inflating your lungs and helping you have a deeper breathing. But with the high flow, it also reduces the level of CO2, but with a different mechanism. Here you can see a physiological study when they asked 10 healthy participants to inhale some radiomarked gas. So you can see the gas distribution, it goes inside the lungs. And here you can see the gas that is at the end of the expiration in the subject, and you can see there is still a lot of gas that is in the upper airway, which means that when the patient will breathe in, before the oxygen or what is inside his body will get to his lungs, he will have to get rid of all of that. When you are using high flow, you can see that it will completely wash out the CO2, all the gas that is in the upper airway, which means that when the patient will breathe in, he will have, right from the start, a lower level of CO2 to inhale. And this also has been shown in tracheostomized patients. So there are 3 patients that also had a CO2 sensor in the trachea, and with that high flow, you can see that they were inhaling a bit of CO2, but as soon as they were set up on nasal high flow with higher flow in the 3 panel here, you can see that the level of inspired CO2 was decreased. So the high flow therapy will decrease the level of CO2 by washing out the upper airway dead space. As the high flow therapy, I told you, is giving the patient warm air, it will also help to improve the mucociliary transport. This has been shown in a sheep model, so it's the trachea of a sheep, and I know that it's not exactly the same in patients, but to do the experiment, it's easier to do and to use animal models. And you can see here that in the experiment, they only changed the temperature from 37 degrees, which is the usual temperature that you would have in your body when you are breathing the air in, to 34 degrees. The humidity remains the same. So here we are just assessing the effect of 3 degrees in difference. So over 4 hours, you can see that the ciliary beat frequency remains stable when you are at 37 degrees and a good humidity. And you can see that the MTV, it's a mucus transportation velocity, remains stable also over time. But just by dropping by 3 degrees the temperature in the trachea, in the experimental model of the trachea, you can see that after 2 hours, the ciliary beat frequency will decrease, and as a result, the mucus will not be transported as rapidly, which means that when you are using high flow therapy and warming the air that the patient is receiving, you will have a better secretion management, and the patient will be able to get rid of all the secretion that he has inside his deep lungs. And this also has been shown in a human model. So this trial is a small sample size trial, so we cannot draw any firm conclusion on that, but it's the trial that has been done by our ENT colleagues, and they included patients that were tracheostomized for an ENT problem. So this patient didn't have any respiratory disease. So they were randomized to have only normal air after the tracheostomy insertion, or to receive high flow therapy at 30 liters per minute and at 37 degrees. And the main judgment criteria in this trial was the number of suction that was made by the participant over the course of 2 weeks. And as you can see in the red plots, the patients that were receiving high flow therapy had a way less amount of tracheal aspiration as compared to the control group. And as in this trial, they had access to the trachea epithelium without any problem because they were tracheostomized. They were also able to analyze the ciliary beat frequency. And as you can see in red, as for the second day after the initiation of the therapy, the ciliary beat frequency is higher when you are using high flow as compared to when you are using room air, which means that by humidifying the hair, keeping it warm, you will have a better secretion management. So now let's see what matters for patients with COPD. So obviously, I've taken that from the GOLD guideline that has been updated recently, but we need to focus on symptoms because that's what matters to the patient. So we need to improve their breathlessness. We need to improve their sleep. We need to have them make less effort when they are breathing in. And as I mentioned, it's important for them to have less secretion, to have less cough, because that is a burden for them. Also, on the bigger picture, we want to improve the survival of the patient, obviously. And as we know that exacerbation are associated to a decrease in quality of life, to an increased mortality, we also want to improve exacerbation rate and reduce it. So now let's see how non-invasive ventilation and high flow therapy are doing with respect to these 6 aims. So let's start with breathlessness. So breathlessness, you may assume that by giving non-invasive ventilation, the patient are feeling less breathless because the device is helping them to have a better, to make less effort to take the air in. And if you look at the data, unfortunately, there is not so many data regarding the improvement of breathlessness in the term of chronic use of NIV in COPD patient. But in the acute settings, we know that in most of the case, it will provide the patient with a relief of his breathlessness. So we know that is something useful. We also know that non-invasive ventilation can cause breathlessness, and that has been shown nicely 10 years ago by Dan Adler, when he showed that when the patient was taking out the ventilator and had deventilation dyspnea, it was because they had patient ventilation asynchrony. So NIV can improve breathlessness, but can also cause a bit of breathlessness, so it needs to be set up properly. So what's about high flow therapy? High flow therapy, for now, we have some data on COPD patients, but I want to show you this study because I think it's very important to show and to see how fast high flow therapy is working and how easy it is to be used. So in this trial, they took patients that didn't have a respiratory disease. It was more palliative care patients that were admitted to the INE for acute respiratory failure. And these patients were randomized to receive either high flow therapy as a first-line treatment or conventional oxygenal therapy. So you can see the conventional oxygen therapy in dark blue and the nasal high flow therapy in dark red. And what is quite interesting to see is that so both of the patients in both groups were quite breathless when they came to the INE, but as soon as they were put on high flow therapy, less than 30 minutes, they had a large decrease of their breathlessness assessed by the modified Borg scale in this trial. This was not seen with the use of standard oxygen therapy. And more importantly, in the trial, patients that received high flow therapy first had to receive less morphine, less opioids than the control group because they were feeling less breathless. So in this trial, they had a crossover design, which means that the patients that were stabilized and improved by the use of nasal high flow were then, after an hour, switched to conventional oxygenal therapy, and the same for the other group. And as you can see, when the patients were initiated, even after 1 hour with no benefit of standard oxygen, they had a benefit of nasal high flow. So nasal high flow therapy is a very effective therapy to improve breathlessness quite rapidly and is less cumbersome to use than non-invasive ventilation, especially when the patients are not familiarized with the use of non-invasive ventilation. And that may be very useful in the acute settings, but also in the chronic settings. Let's have a look now about the work of breathing, and I really love this study that has been done by Lara Pisani in Italy. This trial is a physiological trial when they took 10 patients with very severe COPD. You can see here that their baseline CO2 was 61 milliliters of mercury, and they were already established on long-term non-invasive ventilation. So here we have a very sick population of COPD patients under non-invasive ventilation. And they were kind enough to accept to participate in this protocol when they had transdiaphragmatic measurements of the work of breathing. So you have here the baseline characteristic of the patients, how they are breathing. So you can see that they are breathing quite rapidly, 25 per minute, and that the work of breathing is quite high, 240 roughly. And what is great about this trial is that they compare the benefit of nasal high flow also to non-invasive ventilation. So as you can see, when the patient is set up on 20 liters per minute of high flow, what happens is that the patient has a longer expiratory time, and we know that it's very important for the COPD to prevent for COPD patients to prevent hyperinflations. They decrease their respiratory rate. They have less work of breathing because even at 20 liters per minute, it goes from 240 to 160. So even at 20 liters per minute, high flow therapy will have a benefit on the work of breathing. As you can see, if you push up the pressure, if you go up to 30, you will have further benefit, but sometimes the patient may not tolerate, so you may have to go back to 20 liters. So 20 liters per minute is enough, but we also have to bear in mind that the effect of NIV on the work of breathing is even more important than nasal high flow therapy. You can see the work of breathing drops down to 100 when the patient is on non-invasive ventilation. So I think we need to be cautious. Yes, high flow therapy decreases the CO2, help with the breathing, but it's not as effective as non-invasive ventilation to decrease the work of breathing of our patients. So now let's move to the sleep. Sleep is important because we know that it's the time when we recover, and we also know that the patient with chronic respiratory disease usually have a poor quality of sleep. And it's quite interesting to acknowledge the fact that all the trials that have been conducted in the field of non-invasive ventilation in COPD didn't include a sleep evaluation, whereas it was more the case in patients with obesity hypoventilation syndrome. So this is a cohort study that has been published recently by the Windisch group, and what they've shown is that NIV that was set up properly didn't change the sleeping pattern of the patient. So the patient didn't have more profound sleep, didn't have more REM. The efficiency of the sleep remained the same. But what was interesting is that despite no change in the polysomnography, the patient were feeling less sleepy as assessed by the Epworth Sleepiness Scale. So NIV may not have so much effect on sleep, or maybe we should have a look at some different phenotypes, and maybe some specific phenotype may have more benefits. So what is the impact of high flow therapy with respect to sleep? So some of the physicians are usually concerned because they have used high flow therapy in the context of ICU, and when you are using high flow therapy at 60 liters per minute, it will generate some noise because the nasal cannula are a little bit small, so that will create a noise. But when we are using nasal high flow therapy in the home settings, as I told you, usually we use a flow rate between 20 and 30 liters per minute, which means that the level of noise will be lower. So in this trial, what they have done is that they compare the benefit, the impact of nasal high flow on the sleep pattern as compared to no oxygen at all or to standard oxygen, and they didn't see any difference. In that trial, they also shown that the use of oxygenotherapy was associated with a higher CO2. So, as for non-invasive ventilation, we don't have any strong signals suggesting that nasal high flow therapy is deteriorating the sleep. But what is interesting, and that has been shown in another trial, once again, a very in-depth physiological trial when they assessed the work of breathing during sleep. And what they shown in a cohort of COPD patients is that the benefit that was shown by Lara Pisani during the daytime is maintained during the sleep, which means that when the patient are sleeping with nasal high flow therapy, they have less work of breathing and they have a better CO2 control. So the benefit that we see for ICU patients, for acute patients during the daytime, we have the same benefit with the use of nasal high flow therapy. So the therapy remains effective when the patients are sleeping. Now let's have a look about secretion management. And to be honest, I haven't found any good evidence suggesting that non-invasive ventilation was helping with the secretion. Obviously, we are speaking about COPD patients, so we are not talking about patients with neuromuscular disease, where we know that the use of non-invasive ventilation or cough assist machine may improve secretion. We are speaking about COPD patients that are usually quite breathless. So what I would like just to show you is this trial that we published recently, showing that when the patient is sleeping with non-invasive ventilation, most of them will have a poor sleep quality. And in multivariate analysis, what remains associated with the poor sleep quality is the fact that you have airway secretion that you perceive clinically, which means that if you still have them, the NIV is not effective to improve airway secretion. And we know that in most of the cases, COPD patients will not say that they have less secretion with the use of non-invasive ventilation. Whereas for high flow therapy, we know that it improves secretion management. And we know that from a large clinical trial that has been conducted in Spain. So this result is not the result in a pure COPD population, because it was patients that were admitted in the ICU and that were tracheostomized. So not tracheostomized, that were they were tracheostomized, but they were on the plan was to get them weaned from the tracheostomy. So when the patients were randomized in the trial, they were randomized to either have nasal high flow therapy at 60 liters per minute, we are in the ICU population, or to have standard of care, which means that they had occlusion of the trachea during the daytime. And what they have shown in this trial is that when the patients that were randomized in the nasal high flow group, they were detracheostomized, weaned from the invasive ventilation more rapidly, and the difference was significant because they were weaned 7 days before the other on average. And the reason why they were weaned more rapidly was the fact that they had less bronchitis and less pneumonia, which is, I believe, a direct effect of the fact that they have better management of the bronchial secretion. So we have a clinical effect, and I think high flow therapy is very effective in improving the secretion of the patient, and that's one of the key benefits that may be seen with this therapy. So now let's talk about survival. So the survival for the NIV, we now have evidence that has been produced not so long ago. I mean, now it's almost 9 years, but we know that non-invasive ventilation in stable hypercapnic COPD will improve the mortality. This, we know that from the German study that has been published in the Lancet Respiratory Medicine, where the patients were randomized to stay on oxygen or to receive non-invasive ventilation. And in this trial, the non-invasive ventilation was titrated to reduce CO2 below 25% of the baseline value or to normalize completely the CO2. And when you do that, when you apply NIV effectively and when you target CO2 reduction, you reduce the mortality of the patient. And we know that it's not part of the standard guidelines, and everybody is clear on the fact that we need to provide non-invasive ventilation in this population. For nasal high flow therapy, I'm afraid that for now we don't have data suggesting that high flow therapy may improve survival. This can be easily explained by the fact that the treatment has been used for a more recent period of time, and that we don't have large trial. We have to remember that NIV was started in COPD patients back in 1980s, and we have been using high flow therapy for less than 10 years in the home setting. So I hope that we will be able at one point to have some positive trial, but I have to acknowledge the fact that for now, there is no benefit of high flow therapy on survival. Let's have a look at acute exacerbation of COPD. And I'm showing you the results of a large multi-center randomized controlled trial that has been done in England by Dr. Murphy, where they took patients that were admitted for acute exacerbation of COPD with type 2 respiratory failure and that remained hypercapnic 2 to 4 weeks after the discharge from the hospital. And these patients were randomized to receive either non-invasive ventilation on top of the standard oxygen treatment or to remain on the standard group, which was oxygen therapy alone. And what they've shown is that by the use of non-invasive ventilation, they had a lower rate of severe exacerbation of COPD. So once again, it's been included in the guidelines that you can have a look on the ERS website. It's European guidelines that are saying that if you have type 2 respiratory failure and you remain hypercapnic, you should be set up on non-invasive ventilation, and that will reduce severe exacerbation. So is it the same with high flow therapy? And even if we don't have as good evidence as for non-invasive ventilation, we're going to go through 3 trials that have assessed the impact of high flow therapy on exacerbation. So the first study has been done in New Zealand quite a long time ago, and the study included both patients with COPD and bronchiectatic disease, which means that it was a mixed population, which make the interpretation of the results a little bit challenging. And what was also a bit worrying is that the patients in the trial didn't use the high flow therapy so much. It was 1.6 hours per day on average. So it was stable patients that were on oxygen, and they were randomized to stay on oxygen or to have high flow therapy. So they didn't see any difference in the exacerbation rate. It was 3.6 exacerbation in the year following the inclusion in the control group and 2.9 in the high flow group. But what was interesting to see is that they were able to show a slight improvement in health-related quality of life, and the time to the next exacerbation was also a bit longer. So that was a good lead that maybe something was happening and maybe there is some slight benefit. The second trial that we're going to discuss together is the Danish trial that has been published more recently, where they also took patients with COPD, mildly hypercapnic, but mainly and only using long-term oxygen. And once again, it was stable patients. So these 200 patients were randomized to stay on standard oxygen therapy or to be switched on high-flow nasal therapy. So for those who kept on using the treatment, the compliance was quite good. And the main result of the trial was a positive outcome. And if they look at the exacerbation, the number of exacerbation, the patient in the control group had 5 exacerbations following inclusion in the trial, whereas the high flow group only had 3 exacerbations. So this positive result was also associated with an improvement in breathlessness, with an improvement in health-related quality of life, with an improvement of PCO2, and also an improvement in the walking distance performed on the 6-minute walking test. That being said, there is some caveat to this trial. The first one is the fact that most of the patient, quite a significant number of the patient, stop using the high flow therapy. The second caveat is the fact that it was an open label trial, and there might be a reporting bias regarding exacerbation of any severity. And when we look at an outcome that is less challenging to assess, which is the severe exacerbation when the patient is admitted to the hospital, in that case, we know that the bias is a little bit less important. We didn't show any benefit. There was no benefit of high flow therapy in this study. So that's why we are still not using heavily high flow therapy. That being said, it's becoming standard of care in Denmark now. So now let's have a look at the last trial that has been published last year, and this is a trial by Nagata and colleagues that has been done in Japan. So prior to this trial, they performed a crossover study assessing the benefit of nasal high flow therapy in hypercapnic COPD patients, and they showed that it improved quality of life, it improved symptoms, and was well tolerated. So in this trial, they once again took stable COPD patients, and they were randomized to stay on oxygen or to be established on nasal high flow therapy at an average rate of 30 liters per minute. So in this trial, patients were using it overnight. It was an average use of 7 hours, and they show that the use of nasal high flow increased the time to the first exacerbation of any severity, and they had far less exacerbation in the nasal high flow at the 12 months follow-up. The only problem with these results is the fact that there was strictly no benefit, once again, on severe exacerbation, and that is something that we would like to achieve because they are very meaningful for the patients. On the other side, regarding the other judgment criteria, there was no benefit on health-related quality of life, lung function, or exercise. So we are still looking, and we are conducting in a trial in France to assess in patients admitted with acute exacerbation of COPD if nasal high flow may be beneficial as compared to standard oxygen. So if I was to summarize a little bit the pros and cons and of each of the therapy regarding the 6 aims that we discussed previously, for breathlessness, both nasal non-invasive ventilation and high flow therapy have a benefit. High flow therapy may be a little bit more easy to use. Both therapy do not improve significantly the sleep quality of the patient. Both therapy are improving the work of breathing, but non-invasive ventilation has a more significant effect than high flow therapy. Regarding cough and secretion, non-invasive ventilation is not helping so much the COPD patients, whereas we have the feeling that it's more the case for high flow therapy. For survival, we have a good randomized control trial showing that NIV is beneficial, but we don't have this data on high flow therapy. And for exacerbation, we have a positive trial in COPD patients regarding severe exacerbation, and we have 3 positive trials regarding severe exacerbation of any severities. So, I mean, they have some benefits, and maybe we need to think about what is the good phenotype and to which patient we should give the treatment. But we also have to bear in mind that non-invasive ventilation has been in use for quite a long time, and we know that it's not perfect. We know that NIV is challenging. There is lots of specialists that are dealing with NIV, and we know that they take lots of time for the patient. Even if we are doing now home NIV initiation, it's still something that is challenging. And in this trial, that was a cohort study, we looked at all the patients that were established on an invasive ventilation, and we assessed them to achieve 5 goals. Improvement in PCO2, because we know that it's associated with survival, improvement in health-related quality of life, improvement in sleep quality, improvement in, a good adherence, because we also know that it's associated to improve survival, and lack of significant effect. So if you look at the blue line, you have the COPD patient, and you can see that they were, in most of the cases, compliant at 6 weeks following NIV initiation, but the tolerance of the treatment was pretty poor because 60% of the COPD patients established on non-invasive ventilation complained about significant side effects. They didn't have a very good control of the CO2 and they didn't have any improvement in their sleep quality. So NIV is not perfect. And NIV, I'm afraid to say, does not seem to be associated with a very large life expectancy. This is on the dark line, COPD patients after NIV initiation in a large cohort of 1,800 patients that were established on non-invasive ventilation at this time point. And you can see that the COPD patients have a median survival of 2.8 years, which means that when you start non-invasive ventilation, it's a little bit, and I think it's not a little bit, you need to think about palliative care. Do I need to escalate? Does the patient wants to be escalated to ICU? Will he be able to cope with it, and so on? So the reason why we discuss about nasal high flow therapy is because non-invasive ventilation is not the perfect treatment. We're now going to discuss when to choose what, and you will see, and I will try to highlight that in some cases NIV may be a little bit better, and in some other high flow therapy may be better. So let's talk about exercise, because we know that exercise is important for COPD patients, and it's been also tried for quite a long period of time using non-invasive ventilation to decrease the work of breathing when the patients are exerting, and by doing so, the hypothesis is that they will be able to exert more and then have some benefit. As you can see from this trial, which also assess the impact of the interface that we use, when you are using NIV during exercise in patients, in this case, that were naive for non-invasive ventilation, it doesn't help for the endurance time, which means that it's something that is challenging to do, and not all patients benefit from non-invasive ventilation. So even if it can be used, usually it's not widely used. And the reason why it's not widely used is because it's very difficult to synchronize with the ventilator. When you are exerting, you tend to open your mouth, you tend to change a little bit your breathing pattern, so it's very challenging. And with that respect, using high flow therapy that also decreases the work of breathing may also be beneficial. So this has been assessed in a crossover trial that has been done in France, and they took patients with post-acute exacerbation of COPD that were referred for rehabilitation right after their acute exacerbation. And sadly, they shown that most of the patients didn't have any improvement in the exercise duration time when they were using high flow therapy. This may have been the case because they were using a high flow of oxygen, and that may have caused breathlessness in the patient. But in a large randomized control trial, no benefit was seen. So it's an Italian study that has been published 4 years ago now. They took 170 patients that were referred for rehabilitation in the background of COPD, and they performed the rehabilitation in half of them using high flow therapy that were usually set at around 50 liters per minute, or conventional oxygenal therapy. So the main judgment criteria of the trial was the endurance time, and there was no benefit. They show a small benefit with respect to the 6-minute walk test. It was statistically significant. That being said, the improvement was only 16 meters, and we know that it's below the threshold of the MCID, which means that probably the benefit, even if it's statistical, it's not clinically relevant. Now let's move to patients that are hypercapnic. As I told you before, usually NIV is the first-line treatment. But we also know that NIV fail in quite a few patients because they are not able to cope with the mask, because they are not able to synchronize. So there's a few trials that we're going to discuss that have compared in the crossover design non-invasive ventilation to high flow therapy. And as you can see, so when the patient had to rate the comfort or the easiness to use the device, If you are closer to 0, it's positive. If you are closer to 100, it's more negative. And you can see that the patient felt that nasal high flow was more easy to be used, was more comfortable, and was a little bit, and they were more keen to reuse the device in the future. So, and that confirms our clinical impression. Not having a mask and not having the mouth covered is usually something that the patient will prefer. But it has to be as effective. And we have this trial that has been conducted in Germany when they took COPD patients that were hypercapnic. They had an hypercapnia above 50 millimeters of mercury. So they had a clinical indication of non-invasive ventilation. And they were randomized in a crossover design to receive as a first-line therapy non-invasive ventilation or nasal high flow therapy. So non-invasive ventilation was conducted as per the European recommendation with a pressure support around 16 centimeters of water, which is usually sufficient. And the high flow therapy was used at 20 liters per minute. The trial was a non-inferiority trial, and they didn't show any difference in CO2 control. That being said, I really love this graph that highlights that for one patient, you may have a very different response to the treatment. So if you look at this patient, he had a huge improvement of his CO2 when he was using the nasal high flow therapy. And if you look at the benefit of non-invasive ventilation, it's almost nothing. So, and it can be the other way around, some patients that improved a lot using non-invasive ventilation and not at all with the use of nasal high flow therapy. Which means that COPD patients, and we know that they have different phenotype and they may respond to one treatment better than the other, which means that sometimes if you fail with non-invasive ventilation, it makes sense to try nasal high flow to try to lower the level of CO2. Now let's move to the exacerbation. So we're just going to discuss that very shortly because we've discussed last a little bit with the randomized control trial. We have data mainly on patients with bronchiectasis that shown that in a case control trial, when you are starting nasal high flow therapy, you reduce the rate of hospitalization for acute exacerbation in this first trial. And in this other trial, that was a cohort trial, when they took patients with bronchiectatic disease, it was 78 patients and 25% of them had COPD associated to the bronchiectasis. And during the first year, they had the patient having a regular follow-up, improvement in physiotherapy and so forth. And the second year, they were set up on nasal high flow. So it's not a randomized control trial, but it seems to be they seem to show that there is an additional benefit of high flow therapy in order to reduce exacerbation. Now we're going to discuss the end of life, and end of life is obviously something that, as I told you, patients with COPD that needs NIV, they have a median survival of 2.8 years. And in this trial, it was patients were set up on nasal high flow therapy following an acute respiratory failure, and it was patients that were not able to be weaned from nasal high flow therapy in the acute settings. And as you can see, COPD patients in yellow here were discharged on nasal high flow therapy and had a significant, clinically significant survival in the home settings. So we can also use nasal high flow therapy for the management of end of life. And it was also the case, it's a little bit out of our topic today, but for patients with interstitial lung disease or lung cancer or PH. So where nasal high flow therapy sits in the pathway that we have for our patients. So if you look at chronic respiratory failure and COPD associated chronic respiratory failure, you can divide it in two types. Type 1 is hypoxemic respiratory failure, type 2 hypercapnic. It can be moderate or severe. And we know that since the 80s that if we have moderate hypoxemia, the patient can be established on long-term oxygen therapy and that will improve his survival. If it's a very severe hypoxemic chronic respiratory failure, as I've shown you in the previous slide, patients can be set up on high flow oxygen therapy in the home settings. Then for the patient that have hypercapnia, they can be, once again, moderate or severe. When it's severe, above 50 or 52 millimeters of mercury, you can obviously use non-invasive ventilation. But for now, we don't have any treatment for patients with moderate hypercapnia in the background of COPD. And what I wonder is that maybe we could switch a little bit and change a little bit this this treatment flow, and maybe if high flow therapy with a little bit of oxygen, so it's not high flow oxygen therapy, if it improves the secretion management of our patients, it may be more beneficial than standard oxygen therapy. So we have trials trying to assess that. So for the severe, I think it's going to say also something that is clinically relevant. Then we can wonder if we use high flow therapy in patients with moderate hypercapnia. Usually, high flow therapy will decrease CO2 around 3 or 4 millimeters of mercury, which means that we can make these patients a normocapnic. But I'm saying that just to discuss, because there is no evidence suggesting a benefit for now, but it's for chat. And then obviously, for patients with severe hypercapnic respiratory failure, we still need to use NIV as a first-line therapy. But if the patient fails NIV, we now have an option to try high-flow therapy in the home settings. So the last bit, and it will be the last thing that we will discuss, is we need to think about cost, because we know that it's challenging time for the healthcare system. So we obviously don't have data regarding high flow therapy because it's a newer treatment, but you can see here where NIV sits. So NIV is just for a small part of the COPD population, but it's cost effective. So when your patient is hypercapnic, you should really think about getting him on non-invasive ventilation because it's cost effective, better than telemonitoring or triple therapy. So now, to conclude, I think, and that's my opinion, there is not lots of data supporting that, but that's what I think is true, but we will see if data confirm that. I think that NIV is for patients that have hypercapnic failure, that have lots of an increased work of breathing, and with the use of NIV, you will improve that. I'm not sure that it's really relevant for patients with a frequent exacerbation. I think that patients with frequent exacerbation, if they are not too hypercapnic, should be treated by nasal high flow therapy. I mean, they are the good population, and we need to have data suggesting and confirming my thoughts. We need to assess nasal high flow therapy in this population because by improving the secretion, it will improve the outcome and it will reduce exacerbation rate. I'm just going to give you, before we go to the question, the next talk will be about the role of nebulization and humidification for airway clearance. So we will still remain around something on humidification of the airway. Thank you for your attention. I'll be glad to answer to all your questions.
Maxime, that was excellent. Thank you for a brilliant presentation. You've given us a full view. Obviously, not wanting to steal too much of Matt's thunder for the next presentation, I just wondered whether you could comment on what you thought about with regards to the humidifiers used for high flow therapy. They're obviously of a higher ISO standard compared to that of NIV, and whether that would make a difference.
So I think so. We've tried that on the bench test with our research team, and we saw that both all the ones that were available on the market had similar efficacy regarding the humidification and the temperature that was reached in the upper airway.
Fantastic. And we've got some practical questions that have come in. What should the flow rate be of oxygen in home high flow therapy? And if the patient requires minimal or no oxygen, should this actually be used?
Yeah, that's a very good point and a very good question. For the oxygen, so our experience is that when you have a patient on long-term oxygen therapy and you start him on nasal high flow therapy, you will keep the same oxygen flow. So if he's on 1 liter, it will remain on 1 liter on the high flow device. Then the question is, if he doesn't need any oxygen, I think that you should not put oxygen if the patient doesn't need. In France, we for now don't have a reimbursement for the therapy per se, so we need to prescribe oxygen in addition to nasal high flow. But with hopefully, when we will have more evidence, we will be able to show that, oxygen has nothing to do with the benefit of nasal high flow. It's CO2 washout, it's better secretion management, and it could be used, and I think it will be used without any oxygen.
And just a comment with regards to if someone's on 5 litres via a portable concentrator, what needs to be used with the high flow therapy?
So in our experience, the patient will have 5 liters also on the device, on the nasal high flow.
I wondered if you could comment on high flow therapy and IPF, because I think that this is an area that it will decrease the breathlessness, and you beautifully showed that with the COPD patients, but they're going to need a higher oxygen concentration, and what your experience is and where that fits.
Yeah, that's a very good point. So we are about to start a trial assessing specifically the breathlessness in this population. So what I would say is that for patients with very severe and end-stage disease, the benefit on breathlessness may not be as important because the respiratory mechanics is so altered that when the lung is so stiff, they may not have lots of benefits on breathlessness. In our experience, we had some patients with IPF that were admitted with acute respiratory failure. They were admitted to the respiratory intensive care, and they were on a FiO2 of 50, 60%, and we were not able to win them. And what we've done in that case, we discharged them in the home settings. It was, from the home care provider, quite challenging because on average we had 4 oxygen concentrators in the home setting. So it depends on where you live. Now I'm living in Paris, so it's even more challenging. But back in the day, I was living in Normandy, and the people had more space. So that's something to take into account. But the patients were home. Obviously, it's end-stage disease, so the survival rate was not good, but they were able to spend the last day of their life in the home settings instead of being in the respiratory ICU. So I think for the breathlessness, it may be useful more at the early stages to give comfort to the patient. And then for the very end stage, very severe, it will be, as you said, the hypoxemic respiratory failure that will be able to be dealt in the home settings.
Fantastic. And I just want to go back to the high flow therapy with regards to no oxygen, and maybe you could differentiate between the devices that are driven off the wall and those home devices, because I think you were sort of touching more towards the home devices and at that particular point.
Yeah, it's very important because so everything has started with the ICU, and in the ICU, the high flow therapy is oxygen high flow therapy. It's something that is used for the patient that requires high FiO2. And in the home settings, we are switching to other benefits, and for us, it's not important to have oxygen. So especially if you think about a bronchiectatic patient or mild COPD, they just need to have an improvement of the rheology of the secretion so that they can be weaned. So I think you have the device for high flow, and in the home settings, we have all the devices, the one that are made by Breas, that can be used without oxygen. So you just have to set the high flow, the flow of air, and you don't need to have a flow of oxygen. And we need to, and that's why the title of the talk was nasal high flow therapy and not nasal high flow oxygen therapy. We need to get rid of the oxygen in that.
And you talked about the ICU. Where do you see the role is in the ICU?
So for the ICU, so they've been even more trial because they have started a little bit earlier. I think it has a good role as a replacement for standard oxygen, even though the data are a little bit conflicting for some of the case. If you don't look at the hard clinical outcome like intubation, patients that are using high flow therapy often say that it's more comfortable than standard oxygen because it's also humidified and warm. So usually it's always better to use. But data are conflicting. But right now the guidelines say that nasal high flow therapy should be preferred as compared to conventional oxygen therapy in patients with acute respiratory failure, but not in hypercapnic respiratory failure, for which NIV should be used first.
And slightly going back, have you any papers where the evidence is that high flow therapy without oxygen usage is beneficial? I can't think of any off the top of my head, but I wondered if you could.
No. I mean, so it's not, it's a pre and post study. So the one that we done, we had a few tracheostomized patients that were on room air, and so it was not nasal, but it was tracheal high flow therapy, and they had a benefit. But it's a low quality evidence, but we had like patients that were admitted 6 to 7 times in the respiratory ICU before they were established on high flow therapy, and after they had no hospitalization at all. So I mean, it's not great evidence, but I think we were speaking about nasal high flow in COPD because most of the COPD are now not tracheostomized anymore. But I think another population where it can be useful, and I think that in this population also it's usually they don't need oxygen, tracheostomized patients that have a secretion problem, and we know that when they comes in and out regardless of the cause of the tracheotomy, it's something that have a huge impact on them. It's a smaller population, so there's less evidence, but I think that is something that we will see in the future.
And so in your practice, who do you decide who gets it? Because it's one of those things that if you have no reimbursement for it, it's a bit tricky. And therefore, if you say it's an NIV device because it's got high flow therapy, are you targeting those patients in order to get them, or are you going down a completely different line? So just sort of about how do you get people home? And then after that, I've got another question, a bit more about some other practicalities of home, but then you're off the hook. We're done then.
So what I will say and what we try to do is put them in clinical trials. So we have a large trial. We need to include 400 patients, COPD patients. So the good answer is these patients need to be in clinical trials so that we know what we do. Then, so in France, we rely on the reimbursement on oxygen. So we cannot prescribe high flow in patients that are not on oxygen. For those who are already on NIV, we can obviously use that as an addition to the treatment, and we ask the home care provider to do it freely. Obviously, that depends a little bit on the reimbursement condition. But if you have frequent flyers, if you have patients that are coming in and out with very severe bronchitic disease, I think it's at one point you can give it a try. If it doesn't work, it's something. But yeah, it's challenging for now. But I mean, there's lots of variation across, worldwide and also across Europe. I know that in Italy, in Spain, it's a little bit more easier because they have reimbursement. But for now, yeah, it's challenging.
That's something that the ERS can take up is reimbursement in this area, especially with your key influence. So your last question, and then you can get some lunch. Again, people have been thanking you for an excellent presentation. I forgot to tell you that all the way through. So we've had lots of thank yous. But from a practical perspective, what adaptations to the house do people need to make to get high flow therapy at home? And what cost is it to the patient, especially in the cost of living crisis with regards to the electricity bills? And how can you create the level of airflow?
Yeah, it's a good question. So basically, I think that we should consider high flow therapy the same as PAP therapy or non-invasive ventilation. So it doesn't need, if it's not for end-stage hypoxemic respiratory failure, it doesn't need a lot of adaptation for the home. It needs an electric plug, and that should do it. For the costs, obviously it depends a little bit on the reimbursement. For the electricity bill, it's gonna cost a bit more than a CPAP without humidification, because we know that the warming and warming the water is something that requires lots of electricity. So that may be one of the limits. But if you compare that to the cost of an hospitalization for an acute exacerbation, it's clearly cost effective. And then regarding the flow rate, usually what we try to do is to start at 20 liters per minute for the patients to adjust himself. There's no rush in that case, because we are not in the ICU, so we can start at 20 and review, and we try to go up to 30 because there's a little bit more benefit at 30 liters per minute as compared to 20. But if it doesn't cope, we stay at 20. And for the temperature, we try usually at 31 or 32 degrees, depending on devices, and we try to go to 34. And our Danish colleagues say that they can go up to 37, but I didn't manage to do so, and that may also depends on what is the climate in your country. And we also know that warm air can cause a little bit of breathlessness. So usually we don't go above 34 degrees for the temperature.
And just to put it in perspective, I think the quote is that a CPAP machine is about the same as leaving a light bulb on for your electricity bills. I'd like to thank you for joining the BRIAS webinar series.